So I'm Sue Pemberton, I'm a consultant OT in chronic fatigue syndrome.
I'm Therese Jackson, consultant occupational therapist in stroke.
I'm Dadswell, consultant occupational therapist in adult mental health rehab.
And I'm Hilary Lomas, I'm consultant occupational therapist in forensic psychiatry.
Okay, so for the purpose of today, we're going to talk about examples of practice in the 5 different domains of consultant occupational therapy roles. And we're going to talk first of all about research and development. Okay, so an example from myself is that I will facilitate research opportunities by acting as the principal investigator for a large randomised controlled trial based in Nottingham, but we're a research centre in Aberdeen. And I'll also contribute to the evidence base through my own research activity.
I think as well as actually doing research as part of the role, something else that I do in our team is about actually getting the evidence together, so being able to share research evidence that's out there about our field and have discussions about it with practitioners, talk about how we're actually going to apply that in practice. So that's kind of another element of research that we would do.
For me, it tends to be more around developing a research culture, so supporting the staff to take on research and also looking at providing an evidence base for what we're doing.
And I guess like all of you really, and I know Sue is too, I was taking a PhD, which is obviously doing our own piece of research. I think that then leads into that research culture and disseminating information.
Okay. So in terms of education and professional development, what's the title, is it? Education and practice.
Education and training.
Education and training. Okay, so in terms of education and training, I'll provide education opportunities for staff across the stroke clinical network, and I'll also provide teaching and training both regionally and nationally, for instance at the local university, through national training events, and also by being on the UK Stroke Forum committee to develop our research conference and provide lectures within that.
Okay, I think my post is quite unique in that I'm seconded to my local university one day a week, where I take a role in lecturing around mental health rehab, mental health recovery, perhaps change management type processes, and I also take a lead within our trust on recovery training. So I head up the recovery development group, and we have a training programme across the whole of the trust.
Yeah, similarly, I'm an honorary lecturer at our local university, and I've done undergraduate work, but also been involved in supporting postgraduate education. Enjoyed that, and also been involved, I think as a number of us have, in the masterclasses with COT, which has been interesting.
They were very good fun.
Yeah.
And as well as doing that, the sort of the national training stuff I tend to get involved with is either in my condition, so it's teaching multidisciplinary staff around actually managing the condition, or like master classes, being able to talk just to OTs about actually developing their skills in this particular area. Or some of what I do in the trust is actually maybe taking an element of what we do and trying to help other OTs to take that forward, say like looking at outcome measures or leadership and how they can maybe take those elements and actually bring them into their practice.
One of the bits I really enjoy is the academic mentoring. I've got a couple of master's students, so actually taking them through the master's programme and doing that academic mentoring and supervision I find really quite satisfying.
Okay. So in terms of expert practice, what sort of examples of practice do we have?
I've got, I've retained a caseload of service users who have complex needs. And I suppose one of the remits for me working in secure services is working across the 3 levels of secure care. So facilitating the transition of service users or patients from high secure services through to medium and then low secure services to ensure that their pathway is as successful as possible.
It's quite interesting because I guess although we are different ends of the country, my specialism it kind of rubs against yours, because my remit is going into the specialist secure services and assessing people whether they're ready for open rehab. So I do that as part of our specialist service alongside our consultant psychiatrist. So very much those second opinion type assessments of whether people are ready to move on.
Well, in my case, I'm a clinical lead for a multidisciplinary service, and I've got 2 other consultants in the service with me, an immunologist and a psychiatrist. So we would assess anyone where they have quite complex or comorbid problems, and then for treatment, if anyone has more difficult problems engaging rehab, say severely affected or more complex cases, then I would take them on for treatment, as well as kind of supervising and giving sort of clinical advice to other professionals in the team.
My role in the stroke rehabilitation unit is to provide the consultant lead role for patients who are having rehabilitation, but also to provide consultancy and support and advice to other people working with those who've had a stroke in terms of providing expert practice.
I think one of the things we were both talking about earlier was the opportunity to take on improved clinician roles. So I'm exploring that sort of over the next year or so.
And I think our role allows us to explore and think outside the box, to take on these advanced practitioner type roles as they emerge and be at the forefront to bring about change in the NHS.
Okay, so we'll talk about service development now. In terms of service development in stroke rehabilitation, an exciting area of practice that's been developed at the moment is delivering it using telerehabilitation. So we've been exploring how we can implement the use of goal setting or the use of telerehabilitation to deliver goal setting, and we're rolling that out and evaluating it at the moment.
I can't think of anything to get that moment in time.
I suppose I was mentioning about trying to engage occupational therapy within prison services and looking at the development of those posts, because within the Northwest there aren't a great number of OTs working in prisons, so certainly in terms of looking at those service developments.
Well, one of the things that we've done, we did it quite a while ago, was actually taking the care pathway and doing it very differently. So instead of having doctors assess people as the first assessor, we now have OTs assess people as the first assessor. So kind of redevising the care pathway. And currently we're looking at things like how to treat people who are very severely affected at home better, including things like telemedicine, how you can deliver care differently, which I think therapists are very good at, looking at new ways of being able to provide services.
I think one advantage of the consultant occupational therapist role is being able to work right across the care pathway, from acute care through to rehabilitation and long-term management, removing those service boundaries that have traditionally stopped people looking at the patient's flow through the service, and being able to work seamlessly with all service providers has been really useful.
I think certainly with where I'm currently at in our service, there's lots of reconfiguration going on, and I find a lot of my time is not spent necessarily thinking strategically about the pathway and the service development, but how do we take staff with us at times of change, when people do get change weary, about maintaining the momentum for change and keeping people on board with service changes.
And I think one of the things that OTs are very good at is looking at the patient within service redesign, because a lot of other people look at where the professionals come in, but because we're very patient focused, actually we can build the care pathway around them and actually say, well, what suits the patient best? So I think we can bring a really different perspective to those sort of discussions.
I suppose the other thing I've been aware of since taking on a consultant role is the number of people who've called on me for consultancy around service developments outside my own trust, an area. I'm working with third sector organisations and private healthcare providers, providing input into those services as well.
I guess that's a key part of the role, is actually maintaining that high profile, isn't it, and continue to be ahead of the game and be a forefront in what is coming around the corner next.
And very much partnership work.
And an important element is contributing to national guidelines and legislation as well, and being involved in the development of strategic documents is very important, contributing to the collegeability agenda.
It's something about having influence, isn't it? That as a consultant you can have that influence and you can be involved in those sort of discussions and get an influence at an early stage that maybe most practitioners wouldn't be aware that those discussions are taking place and those sort of strategies are forming at that stage.
Yeah, having the direct link to commissions and influencing at that level.
Okay, so is that enough for examples of practice? So what we can do now is talk a little bit about where, perhaps we can talk a little bit about where our career pathways and how we got to being a consultant. Is anyone willing to start off?
I can start that. Obviously, most of my career I've actually worked in management. So I started as a head OT and a lead OT, but kept my clinical practice up at the same time because we didn't have consultant OT posts at that time, but I really wanted to stay involved in clinical practice. So I made a decision as a manager to keep practicing. And then over the years we developed the local chronic fatigue service and put in a bid to develop it as an opportunity. And because OTs had been so much part of the development through the work we'd already done, it was identified by the medical staff, nursing staff and the managers that we actually needed an OT responsible for that service. So I was actually in the management post that put the bid together to actually get the consultant post funded. And then when that post became available, then I was able to apply for that and move from management into a job that combined all those skills into one role.
That was similar for me, in that there was that recognition of the need, the requirement for the post, and it was very well supported, and being involved in putting the bid together at that stage. I think the thing that helped me in terms of looking at what was required for the post was having a background both clinically and managerially, but also having worked in education for a number of years as well, and being able to pull all that together within the consultant post.
I don't think we can underestimate those components really, because I echo what you're saying, is that I've been a manager for a number of years and I'd kind of reached a crossroads in my career. Did I want to continue a manager and go further up the management level, or did I want to continue my clinical, because like yourself I was a manager with a clinical caseload. And for me what was the turning point was doing a master's.
Yes.
Because that was kind of my deciding factor. I thought I'd do a master's and then see where it led me. So for me that was quite pivotal in my road to becoming a consultant.
When I reflect on my career pathway, it really has been a series of experiences that have contributed to the 5 core elements of the consultant role, with expert clinical practice being the central feature. And consultant roles have allowed many of us to develop our career pathway along the clinical career structure, rather than having to maintain a management role, particularly to be able to develop.
It's interesting, isn't it? Because we've all said we were managers, but managers who retained a clinical caseload. So it shows, doesn't it, that the clinical aspects have been sort of really important to us in terms of our career progression.
I think Rachel's right about the crossroads. I think most people have to choose, and in the past you had to make a choice to give up that clinical contact and go down the management line, or that you had to stay very local in clinical practice, and there weren't the opportunities to do the research, to do the training, to do the education. And actually having a consultant role enables you to develop all of those pathways and not feel that you're stuck on one and you can't actually develop your skills further.
I mean, I describe my working week like the pistons in a car. 1 minute one's up and other ones are down, and I do no research for weeks, and then suddenly I have a week of research, and then I have no leadership that is obvious, and then suddenly I've got 3 people that I'm mentoring, and it's constantly changing. It's always up and down.
I mean, each of the consultant roles has the 5 core components, but they do fluctuate on a day-to-day and a week-to-week basis.
Absolutely.